So we can start with our first candidate. We'll start calling. I'll call the first and second one. Okay, so Dr. Vagish Tripathi, the opening batsman. An interesting case of malaria retinopathy mimicking as viral retinitis. So the next candidate can just be waiting here, Dr. Akshi Sharma, so that we don't waste time in coming and going. All right, please.
Good evening, everyone. I'm going to present an interesting case of malaria retinopathy mimicking as viral retinitis. 41-year-old male farmer by occupation presented to us with chief complaint of fever for 10 days and diminution of vision in both the eyes for 10 days. According to the patient, he was apparently asymptomatic 10 days back when he noticed sudden painless diminution of vision in both the eyes, and there was no improvement in his vision, so he continued his work and presented to our hospital for an eye checkup. On questioning, he told us about the treatment for fever, which was associated with chills and rigor, but no documentation for the same was available. No significant history of past illness. He was treated for fever with tablet acyclovir 800 milligram 5 times a day for 7 days, for which he showed us the strip, and there's no significant family history. He is vegetarian with normal bowel and bladder function, non-smoker or tobacco chewer, non-alcoholic. He is very well oriented to time, place, and person. Pulse rate was 86 beats per minute. Blood pressure was 130 by 78 millimeter of mercury, and respiratory rate was 16 breaths per minute with no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. The head posture was straight with eyebrows at normal level and position. The orbit's margin was palpable, continuous, well-defined, non-tender with no crepitus. The lacrimal apparatus showed no abnormality. Rho plus was negative. Extraocular movements were painless, full and free in all 9 cases. IOP measured at 10:27 a.m. by Goldman applanation tonometry. In the right eye was 9 mmHg, and in the left eye it was 10 mmHg. The right eye uncorrected vision was 460, which improved with pinhole to 560 on his first visit, which after the treatment improved to 624 partial, not improving with the pinhole. And the left eye 618 partial, which improved with pinhole to 612, and on after the treatment it improved to 69. The anterior segment examination was unremarkable with media clear, disc with normal in size, round, pink, Syria 0.3:1, healthy neuroretinal rim, vessels were normal with background showing cotton wool spots, hemorrhages, Roth spots, and retinal necrosis threatening the macula. So provisional diagnosis of post-fever retinitis or the viral retinitis was made, and several investigations were advised, which included the complete blood count with peripheral blood smear, erythrocyte sedimentation rate, random blood sugar, Montu test, chikungunya, and he was called to review with reports. The blood investigations showed normal except for the ESR, which was 50 millimeter of mercury in the first hour with Winthrop, and hemoglobin of 11 gram percent. He was positive for Plasmodium vivax band. So based on this, our diagnosis was revised to malaria retinopathy, and treatment was given with tablet prednisolone 60 milligram 1 OD for 7-day tapering, tablet pantoprazole 40 milligram once a day for 28 days, tablet calcium 100 milligram 2 times a day for 28 days, and tablet chloroquine 1000 mg stat followed by 500 milligram at 6, 24, and 48 hours. So after the treatment, the fundus picture improved. Thank you.
Okay, thank you. So you did viral markers also, because in this case, as you said, it could be malaria, it could also be viral also, and you stopped after 1 week of antivirals. You stopped antivirals.
Antiviral, he was already on the antivirus, so when he presented, there was no improvement in the vision. So it was revised after the investigation. It was revised to malaria retinopathy.
So antivirals were stopped.
Yeah.
Okay, because how long did he have his antiviral therapy? Because he was
1 week.
1 week.
Hmm.
Okay. because it could still be a viral retinitis.
Yeah, was the wheel Felix test done?
No, sir.
Because in such a scenario, I think that also becomes a DD, though lower down.
Okay, sir.
So do we recommend stopping the antivirals altogether? Wouldn't have been, should have continued with the antivirals and done the test and then changed the drug? Because 1 week is probably too short a time, right?
Yeah. So he was on the antiviral from another doctor. When he presented to us, he already stopped that medication, and he only showed the empty strip. So what we did, we asked him to come with the investigation on the next day. So following day, he presented with the investigation where malaria retinopathy was
But
there.
the first diagnosis was viral only.
Yeah, first diagnosis was viral.
Changed it.
Yeah, we changed it later after the investigation.
Yeah, thank you for your presentation.
Thank you.
Now we will be calling upon Dr. Akshi Sharma.
She's on her way.
She's there. So she'll be talking on atypical CSCR masquerading as SLO choroidopathy.
A very good evening, everyone. So today I'll be discussing a very interesting case of atypical CSCR masquerading as SLE choroidopathy. So as we all know that SLE choroidopathy is a chronic autoimmune multisystem inflammatory disorder which is found in 3 in 1 lakh population in India. However, choroidopathy is a rare manifestation of SLE and is considered as a risk factor for severe renal and CNS involvement. And on imaging, we find multiple pinpoint leakage points on FFA, and on OCT, multiple serous retinal detachment, RPE changes, and hyperreflective dots. However, similar changes can be appreciated in atypical CSCR as well, so which makes it difficult to differentiate between the two entities. So the objective of my session will be to diagnose and manage atypical CSCR in a case of SLE choroidopathy. A 39-year-old female from Visakhapatnam, Andhra Pradesh, presented with chief complaints of left eye painless diminution of vision since 5 days. She was a diagnosed case of ANA positive renal SLE since 3 years and was on tab mycophenolate mofetil and tab bisolone 20 mg OD. On ocular examination, the visual acuity in the right eye was 20/40 parts to 20/20, while in the left eye she was 20/50 to 20/20 parts, with anterior segment findings unremarkable and an intraocular pressure of 16 mm mercury in both the eyes. On posterior segment evaluation, the right eye looked fairly normal, but in the left eye, the media was clear, the disc margins were well defined, with a cup disc ratio of 0.3:1, and there was presence of inferior subretinal yellowish white lesions along with inferior exudative retinal detachment. So when we did a fundus fluorescein angiography for the patient, we found that there were multiple hyperfluorescent lesions suggestive of leakage points and the hypofluorescence inferiorly correlating with the exudative retinal detachment, while the right eye FFA showed window defects. As we did the horizontal line scan OCT of the left eye through the macula, we found that there was presence of hyporeflectivity in the subretinal space suggestive of a neurosensory detachment with pachychoroid changes. So with this, we had a differential diagnosis that either it could be a both eye SLE choroidopathy or atypical CSCR. So for this, we sent the patient for a rheumatologist and nephrologist consult to rule out flare-up of SLE presentation. So the patient presented to us after 1 month, and it was gathered that the nephrologist had stopped the steroids to do a renal biopsy to confirm lupus nephritis and started the patient on rituximab. So when the patient had presented to us after 1 month, the steroids had been stopped and rituximab had not been started. And when we did the ocular examination, we found that the left eye visual acuity was 20/40 and there was resolution of the subretinal lesions along with the exudative detachment with organization of the fibrin. Also, there was near complete resolution of the neurosensory detachment in the left eye through the macula. So with this, I would like to conclude that SLE management with steroids can lead to occurrence of CSCR. Thus, it is paramount to identify CSCR and stop steroids as it worsens with steroids. And it is highly necessary to diagnose and differentiate the two entities for correct management of patient. Thank you.
Thank you. Could you tell what was the blood pressure of the patient?
Yes, we checked the blood pressure. I'm sorry, I did not mention it.
It was
here.
normal. Because
Yes,
in
it
such
was-
cases where even renal involvement is there, and if you carefully look at the fundus photo, there is arteriosclerosis and narrowing of the arterioles.
What I gather from here, this steroids were stopped by the nephrologist, and rituximab was started,
Yes.
and the patient presented with this SLE choroidopathy.
Yes.
And then you restarted the steroids.
No, we did not restart the steroids. When the patient had presented to us on follow-up, the steroids had been stopped. So, which made further our conclusion more towards atypical CSCR, as the steroids had been stopped and patient presented with resolution of the detachment along with the lesions. So, it made our
But it
and
could be
organization-
rituximab also acting.
Rituximab had not been started till then. Only steroids had been stopped.
Okay.
So your first diagnosis was SLE choroidopathy, and then
Yes.
you changed your diagnosis to
Atypical CSCR.
Fine. Thank you.
So we can have the next speaker, Dr. Palani Sami.
He's not there.
Whom have you called? किसको बुलाएं?
Yeah, this one. Same.
Palani Sami. I just said his.
Good evening all. The study is on OCT biomarkers and diabetic macular edema and their role in prognosticating the visual outcome. So there is no financial interest in this presentation. We all know that diabetes mellitus is a major health problem with the prevalence rate of diabetic retinopathy with 34% and macular edema is 6.81%. So this macular edema is assessed using spectral domain OCT, which is a non-invasive technique to assess the quantitative and qualitative parameters. So the main objectives of this study is to study the OCT biomarkers and diabetic macular edema and their changes after different intravitreal injections, and to correlate these changes with the visual outcome. So this is a prospective cohort study, and the inclusion criteria are moderate to severe NPDR diabetic retinopathy patients and early PDR patients, and the age group of 35 to 75 years, and HbA1c of less than 8 gram percentage, and OCT signal strength of more than 6. And the exclusion criteria are type 1 diabetes patients and hazy media patients, then past history of any vitrectomy and panretinal photocoagulation and intravitreal injections. Then poor visual acuity and high myopia patients are excluded in this study. So the patients fulfilling inclusion and exclusion criteria are subjected to baseline evaluations of visual acuity, IOP, and a detailed slit lamp examination of anterior segment and a dilated fundoscopy. Then spectral domain OCT images have been taken. Though the intravitreal injection has been given, after that 1 month, the same baseline evaluations are repeated, including the OCT images. Then these parameters that are taken before and after the injection are subjected to statistical analysis. The imaging modality being all the images are obtained using Cirrus HD OCT and fovea centralized images, both HD raster and enhanced depth imaging images also taken, and the 7 OCT parameters are included in this study. First is central macular thickness, in which it is provided by the machine automated measurement, and the subfoveal choroidal thickness is measured in a HD raster scan just beneath the fovea, a hyperreflectivity line of RPE to the sclerochoroidal junction line. Then the height of subretinal fluids are measured using inbuilt caliper tool just beneath the fovea, but perpendicular to the RPE layers. And the height of intraretinal cyst are measured using the caliper tool. The largest cyst that is beneath with present beneath the fovea are included. Then hyperreflective foci are counted manually within the radius of 1500 microns in fovea centered scans, and the ellipsoid zone integrity are recorded within 1500 microns radius. It is an intact or disrupted ones. Then disorganization of inner retinal layers. This is assessed within central 1000 microns with the fovea center. Here disorganization of inner retinal layers are present only if there is any if we are unable to demarcate the retinal layers in the OCT scans. Then the results are being total 42 eyes are included and mean age of 55 with then 29 eyes received ranibizumab and 13 eyes received triamcinolone. Then 13 patients are hypertensive and 2 were already known CKD patients. So on in using the in quantitative parameters from baseline to 1 month, CMT and height of SRF and height of intraretinal cyst and number of hyperretinal foci showed significant changes. Then in qualitative parameters, ellipsoid zone doesn't show any significant change, and the disorganization of inner retinal layer showed significant change after intravitreal injection. Then on correlating these parameters with the visual outcome showed significance for central macular thickness, subfoveal choroidal thickness, and height of subretinal fluid and height of intraretinal cyst. So from this, only these 4 parameters are concluding for the visual prognosis. These parameters if present before giving the injection, if the patient has any hyperreflective foci or any disorganization of inner retinal layers and ellipsoid zone integrity, is a poor prognostic factor. Even after injection also, those patients shows poor prognosis of the visual outcome only. So in this study, apart from previous studies, they have taken one maximum of 6 parameters. They have included 7 parameters, including the subfoveal choroidal thickness also, and it is a short-term study of 1 month period, but previous studies are maximum they have done of at least 3 months or at least up to 12 months. I have given in this study I have done only 1 injection. After 1 injection, in the treatment naive patients I have included. They have included the previous treatment patients also. Then I'm concluding that the OCT biomarkers previously we will be using to see the therapeutic response only, but we can use the prognostic response also. Then presence of hyperreflective foci at the baseline is an indication for steroid injections. Thank you.
Okay, I have one question. How have you correlated with vision improvement in 1 month? Just can you come back to that? Because your aim was to correlate with the vision improvement.
Yes, ma'am.
So I couldn't see the correlation.
They are.
No, was there a, just you can speak out. What was the correlation?
Ma'am, visual acuity we recorded in SEMINALS, ma'am. It's been converted into logMAR values.
So
Then, ma'am, the central macular thickness, these parameters correlation coefficient.
the change. You have to tell us a change. How many of them improved? This you're saying that this was a BCVA in total eyes, but
Yes, ma'am.
what was the change from after giving the injection? How many improved with how many lines? Otherwise, how will we know that the BCVA has increased? Because you took all patients who were more than 5/60 vision,
Yes,
right?
ma'am.
And
Yes, ma'am.
then you say that BCVA in total eyes, you have to see the change, na? That doesn't show in your this thing.
Ma'am, here I have taken the changes in the parameters now.
But the
So
change in
these
vision
changes of mean with the changes of vision mean also, ma'am, has been correlated with the each one of the parameters, ma'am. I haven't taken as
Or it may be
in a
you've not
specific
shown it here, but you
patient.
must have done it. All right. Thank you.
Yes, thank you.
So we call on to our next speaker, Dr. Gaurang Saigal. He'll be speaking on quantitative analysis of vitreous reflectance on OCT in different grades of diabetic retinopathy.
Laser pointer on the screen, please. Done. Just project. I've got this. Okay. Very good evening to one all present here. Today I'm going to talk about a very interesting study done, which is a quantitative analysis of vitreous reflectance on OCT in different grades of diabetic retinopathy, the VRO study. So OCT has been a part of the ophthalmic imaging and offering high resolution cross-sectional images of ocular structure since the past 2 decades. But the OCT has not still been used for application in characterizing the vitreous reflectance. The vitreous itself, as we know, exhibits unique optical properties due to its compositions. It has been proven in some papers that diabetic vitropathy plays an important role in diabetic retinopathy, but it is yet to be studied in detail. So the aim of the study was to measure the intensity and distribution of backscattered light within the vitreous cavity and the structural alterations associated with diabetic retinopathy on OCT. To quantify vitreous reflectance on OCT imaging in different grades of diabetic retinopathy using the Octa software, and also to study vitreous reflectance at a potential imaging biomarker. So first we had the approval, we did a retrospective cross-sectional study. We studied 200 eyes of 100 diagnosed diabetic patients. We took a consent. We excluded patients with myopia more than 6 diopters, history of any ocular surgery, trauma or GDM. And we evaluated BCVA, IOP, SLP, DR status. We did an optosim with the OCT. So the analysis of vitreous reflectance was done by the Octa software. So it is a software created by Doheny Image Reading Center software engineers in USA. B scans are imported from the Spectralis HRA OCT. Retinal thickness is regenerated using this software, and it allows the grader to manually draw or correct if the automatic segmentation is not right. It works on the principle of converting the pixels into micrometers, which yields thickness measurements. So this is how the software looks like, where you select the folder, images are imported back into the Octa software from HRA OCT. The best B scan is selected, whichever we feel has the best quality. Then different layers are drawn, and after that, vitreous thickness, retina thickness, and reflectance are seen in this kind of a report. So the demographic data has 50 patients in 4 groups. First was no DM, no DR. The second was DM, no DR. The third was NPDR, and the fourth was PDR. They were age and sex control matched. So vitreous reflectance mean in log units was 204, the highest in PDR, 112 in NPDR, 140 in DM and no DR, and only 78 in no DM and no DR. Whereas the vitreous reflectance volume was also again found to be maximum in the PDR group, going to 12.46, and minimum in the no DM, no DR group to be around 8.42. The vitreous reflectance mean intensity was also found to be highest in the PDR group and lowest in the no DM, no DR group. The retinal thickness and intensity followed the same graph of the vitreous reflectance, and it was highest in the PDR group of 0.52, and it was lowest in the case of no DM, no DR. All these results were statistically very significant, whereas when we measured the NFL thickness mean and the NFL thickness mean intensity, though the values were higher in NPDR group in cases of NFL thickness mean, and they were higher in PDR group, these were not significant when we did the analysis. The RP cell layer thickness mean was also calculated, which was found to be higher in DM no DR group and was lowest in the PDR group. The RP cell layer thickness volume was found to be highest again in DM no DR group, and the RP cell thickness mean intensity was found to be highest again in DM and no DR group. So the RP cell thickness and mean intensity were highest in cases of DM no DR group. So diabetic vitropathy, as I discussed, is an independent manifestation of the disease process. Though the OCT has been used, it has not been used to study the present conditions. We have found a significant incremental trend in vitreous reflectance. The vitreous reflectance mean increased from 78.2 in no DM, no DR group to 204.2 log units in the PDR group. We also find this incremental trend in vitreous reflectance volume. We also quantified this increased vitreous reflectance mean intensity and vitreous reflectance mean volume across different grades of DR. As studies have already shown, there is an increase in retinal thickness. We have also found an increase in retinal thickness intensity also, which increased from 0.43 to 0.52, going from no DM, no DR to the PDR group. There was no difference in NFL thickness, and though the RP thickness was highest in DM, no DR group, there was no significant changes which were found. So what we know so far that OCT is used for measuring retinal thickness, vitreous traction, posterior vitreous status. We have various biomarkers such as DRIL, HRFD, ICHRM. What does this study adds? That vitreous and retinal reflectance can be used as a potential imaging biomarker, and vitreous reflectance on OCT can also be used to predict progression of DR from a non-proliferative to a proliferative stage. We can study in DME, AMD, and post lasers. Thank you.
Questions for you. The vitreous reflectance which you have studied is from the vitreoretina interface?
From the interface, yes, ma'am.
Okay. And at one stage you say RP cell thickness in DM, no DR, but no DM, no DR.
And the RP cell thickness was found to be maximum in cases with diabetes with no manifestation of diabetic retinopathy, and lowest in cases of PDR.
That's okay. That can be. And then this vitreous reflectance would be how many did you said you took the best of the
B scans
OCT
available,
B
yeah.
scans, because is it reproducible?
It is
And
reproduced.
Is it by various, how many people did those?
Ma'am,
How
basically,
many optometrists or you yourself?
no, ma'am.
How many
Two
doctors did?
trained retina specialists did the grading, and
Was
then
there
a
a lot of
mean was
variation
taken.
between
So, ma'am, the software basically first gives you a reading of drawing the layers of the retina. Then, if we think that there's a problem, we can change it if the interface is not picked up properly. So, in our study, for every case, even after the software said was okay, we did, and we interrupted the vitreous reflectance values, the retinal thickness values.
So for each patient, how many were done to see whether they are?
7, ma'am. Out of the 18, 7
Okay,
scans
seven.
scans were
You took
evaluated,
the best
and
one.
yeah, and then the best one was taken, and then that was sent to the stats guy.
Okay. There could be a variation between person who's doing it, interperson.
Yeah, ma'am, but
variation.
we can decrease the variability because
Yes, it's a new thing. Fine.
yeah.
Yeah, now Dr. Uma Maheshwari. She's not there, no? So we call upon Dr. Kavita Ranjan Bhatnagar. Sorry, Kavita Rajan Bhatnagar. And the topic is to compare obstructive sleep apnea among patients with and without diabetic retinopathy.
Stop? Yeah. Okay, good afternoon, everyone. Thank you, AIOC, for this opportunity. I have no financial interest, no conflict of interest. The topic is to compare obstructive sleep apnea among patients with and without diabetic retinopathy. The proposed mechanism of how OSA can be a risk factor for DR is that it leads to chronic hypoxia and activation of oxidative stress pathway and formation of AGs, and these AGs are responsible for various microvascular changes of diabetic retinopathy. The objectives were to compare OSA in patients with and without DR and to assess the correlation with blood pressure, blood sugar levels, HbA1c, lipid profile, and 24-hour urine protein in the two groups. The study included 85 patients, 45 DR, 40 no DR, and 19, 6, and 20 with mild to moderate NPDR, severe, and PDR. 14 had DME. All underwent assessment for OSA using stop bank questionnaire and Epworth sleepiness scale. The grading was done as, and all the high-risk OSA patients based on stop bank and Epworth sleepiness scale underwent polysomnography. And then calculation of apnea hypopnea index, that is AHI. Based on AHI, they were classified as mild sleep apnea where if the events were 5 to 15 per hour, moderate sleep apnea with 15 to 30 events per hour, and if events were more than 30 per hour, they were labeled as severe deep sleep apnea. So these are the questionnaires. Due to paucity of time, I'm not going to read out the questions, but it was labeled as high risk if yes response was 5 to 8, intermediate if it was 3 to 4, and low risk of OSA if the response was 0 to 2, and total score of more than 10 was taken as abnormal on Epworth sleepiness scale. Longer duration of DM, high HbA1c, LDL HDL ratio, protein urea, and use of insulin were significant risk factors for DR, and high odds ratio shows high risk of OSA in DR patients. Also, high odds ratio shows high risk of OSA in PDR patients, but not statistically significant. OSA did not have association with DME. So, on stop bank questionnaire, a longer duration of DM, LDL, BMI, and hypertension were significant risk factors. And on Epworth sleepiness scale, again, BMI and hypertension were statistically significantly associated with severe OSA. Based on this polysomnography results, in our study, 2 had mild sleep apnea, 1 had moderate, 5 had severe sleep apnea, and 1 was negative out of the high risk, 9 high risk patients. Though there was no significant causal relationship between OSA and diabetic retinopathy, but progression was definitely associated with it. high odds ratio might be due to similar risk factors for the two diseases. So to conclude, OSA could be screened as an independent risk factor in evaluating diabetic patients, especially in patients with uncontrolled progression of DR, despite controlling other metabolic risk factors. Longitudinal studies with observation of effect of treatment of OSA on DR status could better establish their relationship. It was not included in the slide, it was missed, but we did assess the oxygen desaturation index also, which was found to be higher in DR patients compared to no DR patients. It was higher in PDR patients compared to NPDR patients. And oxygen saturation was less in DR patients compared to no DR patients. Though the OSA patients, high risk OSA patients have not undergone treatment, but we are following them up. And post-treatment again we'll reassess them, and I think maybe we'll be in a better position to comment on, the causal relationship. Thank you.
Thank you, ma'am. I think it was a new thing which you did. But only PSG was done only on 9 patients out of all the patients. Like since your study was on sleep apnea, so I was just wondering if it could then be done in all the patients.
Actually, the original plan was that, but the technical problems. We don't have technically trained manpower, and they didn't allow my resident to do it alone. They didn't want to hand over the machine to my resident, so then we restricted it to only the high risk. And so these are the limitations.
Oxygen desaturation was done one time?
It was done one time, and now the plan is to do it on follow-up after treatment. Thank you.
That's
Can we have the next speaker, Dr. Rupal, please?
Good evening, everybody. I would like to thank AIOS for giving me this opportunity to present here today. So I would be presenting our study, the single-center efficacy and safety experience with intravitreal brolucizumab at our center. Brolucizumab is a humanized single-chain antibody fragment which inhibits all the isoforms of VEGF-A. It is the smallest molecule amongst all the VEGF molecules, anti-VEGF molecules. It has a small molecular weight, high molar doses, and a high drug concentration, which makes it an effective drug. Globally, it is marketed as Beovu, and India, it is marketed as Pagenex. Hawk and Harrier study and Kite and Crystal study are some of the landmark studies of intravitreal brolucizumab in neovascular AMD and in diabetic macular edema. The clinical trial data is very different from real-world scenario, and the efficacy is not the same as the effectiveness. Hence, we felt the need to evaluate the efficacy and safety outcome of brolucizumab at our center. We did the study with an objective to check if brolucizumab should be continued as the preferred anti-VEGF agent for our patients with different retinal and choroidal vascular pathologies. Hence, we evaluated the brolucizumab drug in terms of safety and efficacy across all retinal and choroidal indications. It is a single-center retrospective observational study carried out from October 2020 to 2023. The patients were treated with intravitreal brolucizumab across all retinal and choroidal indications, and the patients were treatment naive as well as previously treated with other anti-VEGF agents. We recorded the demographics such as the gender, age of the patient. The treatment indication was noted. The logMAR visual acuity and CSFT, the change in fluid compartment pre and post treatment were noted. Any adverse events, if any, were noted. We studied the change in the logMAR visual acuity, the change in the CSFT, change in fluid status in different compartments at the end of 4 weeks post-injection, and the adverse event count was recorded. 813 injections given in 405 eyes in 354 patients were studied. The age distribution in our population was between 25 to above 80 years, and the mean age was 60 years, was around 60. The most common indication in our population was CNVM and PCV, followed by diabetic macular edema. It was found that there was a significant increase in the visual acuity post-treatment with brolucizumab at the end of 4 weeks, and there was a significant reduction in the central subfield thickness post-treatment. There was a change or resolution in the PD, SRF and IRF volume in all the patients post-treatment at the end of 4 weeks. 3 of the eyes developed intraocular inflammation, of which 1 developed posterior segment inflammation. The patient here presented with vitreous floaters, and there was vitritis as seen in the fundus image, and there was vitreous haze. The patient was taken up for the patient also underwent fundus fluorescein angiography, which showed a diffuse leakage in the later phases of the angiogram. So we went ahead to, the patient was initially treated with oral steroids, and hence because the patient was not responding, 3 to 4 weeks later we went ahead to do the pars plana vitrectomy and took the diagnostic vitreous biopsy sample, which showed a high cellular content, which was predominantly the small lymphocytes against a proteinaceous background. So this is a fundus picture of the patient 1 month post pars plana vitrectomy, and the visual acuity improved to 6/9. This is the OCT, and this is at the final visit in 2023 October. Inflammation has been reported with various other anti-VEGF agents as well. We conclude by saying that intravitreal brolucizumab is an effective drug in various retinal and choroidal pathologies. The risk of intraocular inflammation is comparable to the other anti-VEGF agents used in clinical practice, and hence it should be continued for different retinal and choroidal pathologies with proper monitoring of the patient symptoms. Thank you.
So the patient who developed intraocular inflammation, what was the profile of that patient? I mean, it was the first injection or a repeat injection?
Yes, it was the first injection.
And what was the gap in between the 2 injections which you gave?
Ma'am?
First injection and the second injection was after how many weeks? 4 weeks?
Ma'am,
6
minimum
weeks?
4 weeks. Minimum
No,
4
minimum,
weeks.
maximum.
4 to 6 weeks. Actually, it was mostly the patients were PNR patients, like as and when required.
So they were already under treatment.
Yes.
Rupali. Rupal.
I'll call the next one. Can we have the next speaker, Dr. Ansi, please?
Good evening all. Myself Dr. Ansi from Anandapuri Hospitals, Trivandrum, Kerala. I am presenting an artificial intelligence model for early detection of Alzheimer's disease using fundus images. My technical support is from Mr. Ansar A. from Indian Institute of Information Technology, Kottayam, Kerala. Sir, my contents. Alzheimer's disease is a common neurodegenerative disease, and it is the leading cause of dementia. The long progression period in Alzheimer's disease gives a chance for patient to get early treatment by having routine screenings. Nowadays, the current diagnostic modalities like PET scan, MRI scan, CSF analysis, etc. are expensive, invasive and time consuming. As we know, the retina, the innermost neurosensory layer of the eye, which is directly connected to the brain via the optic nerve, is an easily accessible extension of the brain. Retina can be considered as a platform to study neurodegenerative diseases, and retinal imaging can be used as a tool for early detection of Alzheimer's disease. It has been estimated that 50 to 80% of cases of the most common form of dementia, Alzheimer's disease, remain unrecognized even in high-income countries due to challenges in detection and diagnosis. Advances in machine learning have contributed significant effort to facilitate the clinical diagnosis of AD. Published work have largely focused on MRI, PET imaging, CSF biomarkers, and the study demonstrated promising results, but their clinical application is limited because of the expense and invasive nature and consumption of time. It's better to implement a cost-effective, simple and efficient system having better accuracy for early detection of AD and the identification of methods to predict the risk of developing AD would be of great value for healthcare systems. Regarding existing AD diagnostic models that include memory test, brain imaging and numerical laboratory tests, including CSF analysis, imaging including MRI, PET CT and CT scan. And my proposed AD diagnosis method include memory tests, which include mini mental status examination and using fundus image. It's an analytical cross-sectional study. It's place of study in the Department of Computer Science and Engineering, Indian Institute of Information Technology, Kottayam, Alzheimer's and Related Disorders Society of India, Kerala chapter, Department of Ophthalmology and Department of Neurology, Anandaburi Hospital, Trivandrum. We implemented a multi-stage architecture for this study. First, retinal blood vessel map generation. Second is disease classification. This is the framework for retinal blood vessel segmentation. After pre-processing, we fed the images into proposed deep learning model. The segmented output using proposed model, that retinal blood vessel tree as final output. Initially, the data is pre-processed, such as convert color images into grayscale, cropping of the images into appropriate pixel shape, so that it is ready to be fed into the model. This is the blood vessel segmentation using UNet. Utilizing a publicly accessible database called Drive, it has a total of 40 retinal images. The collection of 20 images has been designated as the training set, and a single manual segmentation of the vasculature is offered for the training images, and the remaining images has been designated as a testing set. A set of 100 real-world external images has been captured with support of healthcare professionals in Trivandrum using a non-metriatic fundus camera from the clinical setup, and the same was used and tested. And there are 26 patients in AD, and the normal controls, that is 28. And we got 48 images from both eyes in AD patients. A total of 532 images were generated by applying augmentation techniques in AI. The figure shows the random input image from the training and set along with its matching. The training loss, training accuracy, validation loss, and validation accuracy are found after the training is finished, and a graph is plotted displaying both training loss and validation loss, as well as training accuracy and validation accuracy. Here, as the number of epochs rises, validation loss and training losses are reduced, and in case of accuracy, as the number of epochs rises, training and validation accuracy will get increased. It's like in training and validation accuracy. This is graph plotting training and validation loss. Various evaluation metrics has been calculated, and we got an accuracy of 0.943. Then disease classification was performed by using transfer learning technique. I have used ResNet pre-trained models for this purpose. Created a model for classification with the support of a pre-trained model called ResNet 50. Pre-trained on ImageNet dataset is taken as the base model. In the last year, we ordered a fully connected hidden layer with the 256 unit for more learning to be done on the target dataset. In the output layer...
Dr. Ansi, can you just please conclude? I'm sorry.
Okay. This is the model using ResNet 50 confusion metrics and training validation accuracy. This is the model using ResNet 50 AUC curve. And we got an accuracy of 93.2, sensitivity of 86.27, specificity 100%. And regarding future works, let me have a word on our future work.
Just summarize.
Okay. So the proposed model will provide a simple low-cost, labor-dependent approach to identify AD patients in a community settings with reasonable accuracy and sensitivity. And the identified patients can then be referred to, followed up at the tertiary facilities with the diagnostic evaluation and subsequent multidisciplinary management. These are my references and future works.
Were there any findings?
Yes, sir. We got a base model using ResNet 50 in deep learning method of AI, which classify the retinal image into Alzheimer's or not an Alzheimer's normal control.
But there will be so many confounding factors like hypertension, diabetes.
Yes, we are excluded all the hypertension, diabetes, CVA, stroke, cardiac disorder.
Mention
all.
about the exclusion criteria.
Okay, ma'am. Okay.
Thank you.
Thank you.
With this, I call upon Professor Gopal S. Pillai for his presentation on results of first government-supported clinical trial network-run registry for diabetic retinopathy.
Thank you very much. So this is the results of the first government-supported clinical trial network registry. We formed a clinical trial network based on NBM, BIRAC, Government of India. So these are the 6 sites in the network, including South, West, East, and Center. And this was a sanctioned second objective of the network to form a registry. And it had about 3,699 patients of diabetic retinopathy in the registry over 2 years. So there were a lot of quality checks that we had mentioned because there were 700 data variables for each patient in the registry, each of those 3,699. So there was a lot of quality checks. And these were the number of audits conducted by central agencies as well as the lead site. And objectives of this particular study is to look at descriptive statistics on diabetic retinopathy presentation among these patients. Are there any geographic variations in the presentation from different regions of India? What are the factors affecting visual acuity? And what are the results in the management of diabetic retinopathy from this large database? These are cases across all geographic regions. And as you see, this is a tertiary care center data. So proliferative diabetic retinopathy significantly was high. And you could see here that in non-proliferative diabetic retinopathy, moderate in PDR was higher. And in proliferative diabetic retinopathy, lasered PDR, vitreous hemorrhage and tractional retinal detachment were there. Now, across age groups, when you looked at it, West had a lot of older patients, and women significantly were higher in the South zone. You could see that when you looked at the comorbidities, these are the smoking and the alcohol, you could see that East had the highest amount of smoking, and South had the highest amount of drinking in the diabetic retinopathy patients. These are the comorbidities. I just want to take a minute to say that central zone was represented by Chitrakoot, which is a rather rural zone. And you can see that the hypertension, coronary artery disease, CKD, dyslipidemia are all so much less in the central zone as compared to here. You can just see this dyslipidemia, 47% versus 1% in the rural zone. So distribution of diabetic retinopathy into, we had the logmar scale, and you could see that in the West, they had the higher visual acuity presenting, and in the East, the visual acuities on presentation was lowest. Obviously, non-proliferative diabetic retinopathy had better visual acuity than proliferative diabetic retinopathy. And now coming on to the factors which influence vision, the patients were grouped into best corrected visual acuities, more than 0.5, which is less than 6/18, or more than 1 logmar, which is more than 6/60. And we looked at all these factors, and logistic regression analysis was performed. Because of the high numbers, age, BMI, diabetes duration, coronary artery disease, dyslipidemia, hemoglobin levels, cholesterol levels, and urea levels were significantly associated with worser visual acuities than 6/18. These were predictors. But then we had, in the eye, obviously, proliferative diabetic retinopathy, vitreous hemorrhage, and tractional retinal detachment were having a poorer visual acuity. So we did a logistic regression to find out which among these are more appropriate. And so we adjusted odds ratio was done. And then a p-value was again calculated. And then we found out that BMI, diabetes duration, hemoglobin, and urea are the 4 factors which can actually predict visual acuity less than 6/18. Similarly, even though all these factors, including age, BMI, diabetes, coronary artery disease, dyslipidemia, all had significance, but logistic regression showed that diabetes duration was the only factor which had predicted visual acuity worse than 6/60, apart from diabetic retinopathy grades, vitreous hemorrhage, and tractional retinal detachment. Now let us look at the treatment results of diabetic retinopathy here. Vitreous surgery had the highest change in visual acuity, followed by intravitreal injection and laser. The other medications include the posterior subtenon injection and the NSAIDs and the antioxidants, etc., which did not have any statistical difference. Now coming on to the change in logmar with the treatment, is that the different injections and the vitreous surgery which showed the maximum logmar improvement, and laser had in fact a little less visual acuity. These were the types of intravitreal injections and change in BCVA. So to conclude, in 3,699 patients across India, presentation of DR to tertiary specialists is very late. Many patients have PDR by the time, about 50%. There's a gross regional variations across zones in terms of gender, age, mode of presentation, visual acuity, etc. BMI, duration of diabetes, hemoglobin, urea. These are the 4 factors which predict vision below 6/18. And duration of diabetes is the only factor which predicts visual acuity below 60, other than the ocular factors including PDR, vitreous hemorrhage, and TRD. Treatment with surgery, laser, and injection provides visual improvement in the real world scenario also. Thank you very much.
It has been a very extensive study which you have done. What was the time period?
This started in 2019, but the registry started in 2020 mid, and it went on to 2023 early. So it's 2 years.
So you had camps where?
No, they were all tertiary care, hospital-based data. It is a clinical trial network across the hospitals. MOUs were signed. There were similar harmonization of the standard operating procedures, ethics committee harmonizations. A lot of these things were done.
I think it's a very good study.
Thank you.
So that ends up a session of diabetic retinopathy and medical retina 4. Now we'll go on to the next session of semi-finals, in which so we have already got 3 names. One is Dr. Mudit Tyagi. Presenting author Dr. Sarang Hansraj. Second would be Dr. R. Unni Krishnan Nair, and third would be Dr. Chaitra. Yes. So the 4th name will just come up after our summing up. So should we right away go with this, or should we have a picture with all and then go on to the next session? I think we'll have a picture with all our earlier speakers. But I think the panelists feel we continue. And the 4th candidate will be announced later on, so you all keep sitting in the heat. So please, the first, Dr. Sarang Hansraj.
We'll sum up, then declare this thing, rest can go.
तभी तो मैं कह रही थी picture ले लो. So I think we can go on with the picture so that we don't keep all of you here in the heat. So all the speakers, please come up. So there's a hairline difference between the person who has got it. So I will announce the name. Her name is Professor Gopal S. Pillai. He gets the highest in this session, so he will stay on for the semi-finals. All of them are very, very good, and there's very little difference. So it's just a matter of 1 mark here and there by all of us, similar marks. So we go on with Dr. Hansraj once again. इधर लिखते थे ना, क्या नाम है? नहीं, वो जो हमने अभी इधर लगाना है, चाहते हैं ना. Please start.
Good evening, everyone. So I'll be presenting our results of the real-world outcomes of intravitreal brolucizumab for persistent diabetic macular edema. So at the outset, I'll declare that we have no financial conflicts of interest or any interest with this presentation. So over the past 2 decades, anti-VEGFs have become the primary mode of treatment for center-involving diabetic macular edema. But there's a significant chunk of patients in which complete resolution of fluid does not take place despite persistent intense therapy. These patients may be labeled as persistent DME, recalcitrant DME, resistant DME. There's no clear-cut definition as per the number of injections or the treatment regimen to define such a patient, however. Recently, in 2022, the FDA has approved brolucizumab on the basis of the Kestrel Kite studies to treat diabetic macular edema. And since more molecules can be packed in the same amount of volume, we have decided we wanted to investigate its effect on persistent diabetic macular edema. The primary outcome was to see the effect on visual acuity and central retinal thickness, and secondarily to see any incidences of any adverse effects, primarily intraocular inflammation. It was a prospective interventional trial of consecutive patients of persistent center-involving diabetic macular edema at a single center tertiary care center in South India, conducted between January 2022 to August 2023. Center-involving persistent diabetic macular edema, as per our study, was defined as any edema persisting despite 3 consecutive monthly injections of the same agent or any combination of agents, intravitreal steroids, or different anti-VEGF agents. We excluded any patient which had macular pathology in which the visual acuity would be affected by that coexisting pathology, or any patient who had had any prior episodes of non-infectious intraocular inflammation. Patients were treated on a pro-rata basis. At every visit, the visual acuity was checked by the Snellen's acuity chart, a comprehensive ocular examination was conducted, and OCT was taken either by spectral or swept source modalities. The systemic status, it was ensured that the systemic status was well maintained and blood sugar levels were well controlled for all patients. At every visit, patients were also meticulously checked for any signs of intraocular inflammation. They were also kept under close follow-up via teleconsultation. If the eye was to be injected, it was always checked prior to injection. So what we found that we included 13 patients with 19 eyes. Of these 19 eyes, 13 eyes would had proliferative diabetic retinopathy. The mean age of presentation of patients was 64.4 years, and it was well distributed amongst males and females and unilateral bilateral eyes. The other coexisting comorbidities also noted by us were presence of hypertension, diabetic nephropathy, dyslipidemia, anemia, and 4 patients were on insulin therapy. So while starting therapy, the median visual acuity of each of the patients were 20/50 on the Snellen acuity chart. And of the 19 eyes, 18 had received prior intravitreal anti-VEGF agents, while 1 patient had received 4 prior Ozurdex injections. 6 patients had also received a combination of intravitreal steroids, while 4 patients had received diabetic laser photocoagulation for macular edema. So over the course of 20 months, a total of 63 injections were given, with a mean of 3.3 injections per eye, with a mean re-injection interval of 11.1 weeks. After the last follow-up of a median of 13 weeks after the last injection, it was noted that the visual acuity improved to a median of 20/44 on the Snellen acuity chart. There was a 54.1 reduction in the central retinal thickness over the course of the treatment, and there was complete resolution of fluid on 5 of the 19 eyes. It is also noted that 52% reduction took place just after 1 injection, and which is also found to be statistically significant. So the results were then analyzed by the Wilcoxon's sum rank test, and the change in visual acuity and the reduction in central retinal thickness was found to be significant. 1 patient had an episode of acute non-granulomatous iridocyclitis with spillover intermediate uveitis. This occurred after receiving her 2nd injection. She was treated by intense topical corticosteroids, and once the inflammation resolved, she was again treated with further 3 intravitreal brolucizumab injections. At the last follow-up, the complete resolution of edema was noted, and the visual acuity improved to 20/20 on the Snellen acuity chart. The strengths of our study are that it's a real-world study which contained all manner of patients, whether proliferative or non-proliferative diabetic retinopathy, whether treated with anti-VEGFs or steroids in the past. However, the sample size was small, the period of follow-up could be longer. Also, since it's a real-world out study, patients could not be followed in a very tight regimen, which may have reduced our effectiveness. To conclude, intravitreal brolucizumab is effective and provides a ray of hope for persistent diabetic macular edema. And crucially, when the mean re-injection interval of 11.1 weeks, it may offer some ray of hope for such patients. Thank you.
One question, Dr. Hansrath. You said there was one patient who had intraocular inflammation, and after treating you again started with brolucizumab only.
So this patient in particular had received 4 prior Ozurdex injections. She also had
it's a little difficult to explain to the patient, like he's already had an inflammation and the same. I thought it was you could have changed.
Actually, with our experience not in the trial study and with other diseases, Paginax actually has a much lesser incidence of inflammation as reported in landmark trials. So
No, but if the patient has already had an inflammation and after treating you again, give the same injection again, I would take it with a pinch of salt.
Well,
I don't know what others would have to say. All right, thank you.
Thank
Good
you.
presentation. Any more questions?
So next presentation is by Dr. Unnikrishnan Nair. He'll be speaking on outer retinal microvascular changes in Mactel differentiating patterns.
So we'll be talking about Mactel. So it's a clinical diagnosis that we all know. Starting with graying of the retina, then we said pigmentary changes, and finally ending in scarring, which makes the diagnosis pretty obvious. And this is one of the dreaded complications where you find a development of a choroidal neovascular membrane picked up well on angiography, though the OCTA forms the bedrock of diagnosis in secondary CNVIMs in Mactel. You get beautiful images of the vascular network in the layers. And this is what I want to show you. This is the progression of the layers in which you see in the avascular zone, which is supposed to be avascular by name, you see a network, contrasting to a non-proliferative Mactel where you don't see anything in the avascular zone. So this is the crux of the paper. Sometimes in the avascular zone, you see vasculature. And that vasculature is what we call OCT-based microvascular, outer retinal microvascular changes. And it is associated with this particular new OCT finding called aura, or outer retina associated hyperreflectivity. So what is aura? You see it with the study was 117 eyes, of which 35 eyes had aura. Both of them had equal OCT and OCTA findings. So this is what you mean by aura. It's a hyperreflectivity in contact with the RP. You see a hyperreflectivity in the outermost retinal layers in contact with the RP is called aura. And what happens, it may be due to pigment migration, and it may be due to vascularization. So that is what we're studying here. The OCT features studied were those related to Mactel, including hyperreflective foci, the formation of hyperreflectivity, pigment plaques, and eventually, this is something that was important. We studied the change of the contour, that is the retina going down. That's called subsidence. That is the vertical support of the retina is not there and it goes down to the outer retinal layers. But we also studied vascular features. That is the presence of a double layer sign, as you see here, and also the eventual features of a subretinal neovascular membrane. The OCT features studied were the presence of a right angle vessel vascular invasion, which I'll come to later, a retinochoroidal anastomosis, a vessel going throughout the length of retina, and eventually the formation of an SR-NBM. So these were the findings. You can see that we studied the subsidence, the loss of the ellipsoid, the cystoids, and this is important. Whenever there was an increase in subsidence or easy loss, indicating the atrophic element, you could find there was vascular invasion. The plexuses would actually go down. So on the right-hand picture, you can see what a vascular invasion is. It is not a CNVM. On the left-hand picture, you see the OCT shows a CNVM. So the crux of the study, the vascular invasion was always associated with subsidence, the retina going down and the vasculature appearing in a level it is not supposed to be there. A retinochoroidal anastomosis was when the retinal changes happen throughout the layers, and when they touch the choriocapillaris, a double layer sign formed. That is a lateral growth of blood vessels in the potential space of the sub-RP space. Why is this extremely important? This is probably the first flag you can get of a CNVM happening, and that is the significance of the study. Subsequently, MNVs happen, and they were always associated with intense atrophy and pigment clumps, 100% association. So the theory of this aura, it's an OCT find. It's either because the retinal layers go down, or it is because of some new vascular changes that happen. And how do you differentiate it? This is a pictorial representation. You have hyperreflective changes, and as these changes collapses, you see the retinal layers going down. This is what we know. But you can transpose it on the vascular. You have the superficial vascular plexus and the deep vascular plexus. And you see the changes. This is the retinochoroidal anastomosis happening. But along with that happening, you see the layers going down because of subsidence, of atrophy. And finally, the deep vascular plexus is in the avascular area. This is called vascular invasion. It's not supposed to be there. And when it touches the choriocapillaris, you have a double layer sign. This is probably the pre-proliferative stage of CNVM. Everything in blue is a non-proliferative before a CNV happens. The red is when a CNV happens. So there's a very small window of opportunity for us. And that is demonstrated by this identification of the double layer sign along with identification on the OCT of our blood vessel traveling through the course of the whole retina. So why is this important? Mactel is a degenerative disease. It produces a secondary vascular change. The vessels grow through all the layers. The vessels hit the chorea capillaris. You get a CNVM, but you have a small window by which you have a double layer sign, and you can potentially identify pre-proliferative Mactel and all the key changes that can really damage your thing. So a vital pre-proliferative flag. That is what this study is about. The DLS in Mactel in the presence of this OCT finding called aura. There is no rationale to treat it at this stage, but you have a great way of saving severe visual loss due to an SRMV formation. Thank you.
So do you have any experience of treating such patients when you saw the double layer sign and you treated them?
No, this is very new, madam. This is the double layer sign is, even when you find the double layer sign in a non-exudative, you are not allowed to treat it. But the main point is that 5 to 18% of these people will convert to a full-blown CNVM in 1 year. So you have the you have the opportunity to tell the patients that they have to have a regular follow-up, even once every 3 months, follow up with OCTA to make sure it doesn't progress.
My question was, these were your patients.
Yes, ma'am.
And you diagnosed them to be having SRMV. Did you treat them?
With the SRN patients, we treated.
And how much improvement could they have? Because they were already a Mactel and there already a degeneration taken place. So how much did they improve?
So they would improve, but the final improvement would all depend on the ellipsoid zone loss. How much?
So in your study, how much did they improve? How much could you get the vision back? That's just my question.
The treatment is not a part of the study, madam.
But I'm asking you.
No, if you're asking me, generally they improve well. They improve. It depends on how early you catch the CNVM.
All right, thank you.
Thank you so much.
Can we have Dr. Chaitra Jain?
May I start? Okay. Good evening, esteemed judges and my dear friends. Today I'll be speaking of some interesting insights that we've had in our research in Narayana Nethralaya. I have no financial disclosures. We know that 101 million diabetics are there in our country, and at least 21 million of them have already got sight-threatening diabetic retinopathy. So we are on the lookout for a definitive treatment for our patients. Vitreous biomarkers have already shown in previous studies that they can predict who can get the disease and who can be treated with what molecule. So vitreous sampling is rather difficult. It's a surgery, it's risky. You also have tear samples at your disposal. You have aqueous which can be collected during the surgery or during the first injection, and even blood. I mean, all diabetics really test the blood every other day for their sugar levels. So that's what came about with this BRIGHT study, where we wanted to look at all 4 samples, see how well the biomarkers correlate amongst these 4 samples in the vitreous aqueous serum tears, or the VAST study. We also wanted to see whether they correlate positively and strongly. So 22 patients who were undergoing diabetic vitrectomy, the samples were done on the same day, all 4 of them were collected. This is in brief of how we went about with the study. In our in-house grow lab, we not only stored the samples, we segregated them and eventually isolated these biomarkers, both cytokines, chemokines, and all the other inflammatory markers. We looked at 53 biomarkers, out of which 48 were positive, and we used different quantifiers because one did not really suit all of them, and we found an absolute concentration at the end of the study. What we saw was that the protein concentration was highest in the plasma as expected, and we used something called as a normalization technique to make all 4 of them comparable. Now, if you look at the image on the left, you will see that the biomarkers from ocular fluids are grouping together as against that from the plasma. Now, hold that thought because that's rather important. We also use something called as hierarchical clustering, wherein we were able to cluster together those biomarkers that correlated better across the different 4 samples. If you see cluster 2, there is a good correlation there between vasculogenic and inflammatory biomarkers. Now, what we found, interestingly, is that 80% of them correlated strongly between vitreous and aqueous, which is extremely good news for us. And also, when you looked at all 4 samples, it was around 28%. This is a Sankey plot. This is very important because it shows the complex interplay between sample sources and the different biomarkers. The ones that are shown in red arrow are these here. These are the clinically relevant ones and potential drug targets. Besides the usual suspects of VEGF and angiopoietin 2, you see few other players there that are rather important, which are again pro-inflammatory biomarkers. Yes, to sample every patient for all 4 of these on a single day across disease spectrums was rather difficult. We need to keep in mind that systemic conditions can cause variability in these samples, but the test is repeatable. We are on the brink of potentially finding a target that can be better addressed, giving long-term benefits. This is the first study that compared 4 different samples. We saw an extremely good correlation between vitreous and aqueous. We saw a reasonable correlation with tears as well because of extraocular spillover. Now, this is important. We saw that organ-specific sampling, because of that grouping, seems to be a little bit more reliable than general body fluids. And then, friends, surrogate sampling is now possible through non-invasive or less invasive sources such as aqueous and tears. Let me show you with an example. This is a patient who's diabetic, was given anti-VEGF, and look at the response. He's not very, very happy. So we looked at his aqueous that was taken during the first injection. You can see that the VEGF level is rather low. Intuitively, we switched the patient to steroid and look at his resolution. Fantastic, isn't it? Now, this is another lady. She came to me and said, "Ma'am, I hate injections. You have to give me the least possible number of injections." We looked at a biomarker profile. Looking at this, you would say, "I think again, VEGF is low, ma'am. I think steroid would be a better option." We gave her a steroid and look at the response. Fantastic, isn't it? Imagine if you could get the same biomarker profile non-invasively, most easily, either from the tears or blood. The patient would be happy with less injections. I would be happy because she's responding well to a specific treatment. So friends, we're on the brink of a very, very bright future. We have a non-invasive biomarker that is repetitive. It can monitor progression for your patients, and it offers, most importantly, something called as bespoke or personalized therapy for patients. This is definitely going to improve their compliance. Dr. Gopal Pillai already spoke about eventually in the real world, you want to offer the best treatment for these patients for the best outcomes, and here we are. Thank you so much, friends. I thank my entire team for this support, and thank you, judges.
I think it's a really wonderful thing what you're doing, but all these interleukins, VEGF, they were all studied in your institute?
Yes, ma'am, 53 of them. We picked up the 53 most important ones because it takes a long time and a higher volume we need because, collecting the samples is challenging.
So it is all done in your biochemistry lab?
Yes, ma'am. We have a lab called as the GROW lab. So we have our facilities to sample all of them. Yes, thank you so much.